Okay, so as you're finding your seats, I'm just going to give a little background as to this session. So this session is entitled Moving Fluidly Across the Translational Spectrum, and it's going to focus on the current opioid crisis. So I'm Catherine Chen. I'm from UCSF. I'm an assistant professor. My co-moderator is Mike Mathis from University of Michigan, and actually our entire panel is also from University of Michigan, so I feel a little outnumbered this morning. Go blue. So what we're going to do is we're going to introduce the speakers right before they give their talks, and we will save all the questions for the end. But I don't have to emphasize to this audience how important the opioid epidemic has been to the current public health situation, and we as anesthesiologists are perioperative consultants, so this is something that we obviously all care about. So our panelists have a very diverse background, and they are approaching the opioid crisis from different research perspectives. So we have the clinical, basic science, and behavioral health approaches to what we can do to improve the care of our patients. So Mike is going to introduce our first speaker.
Our first speaker, all of our speakers are from the University of Michigan, but the first speaker will be Dr. Jennifer Walshy. She's an associate professor for the section of plastic and reconstructive surgery at the University of Michigan. My experience working with her has really been as a resident in the ORs. I've been up on call with her. Maybe she may not remember this, but I've spent a couple late nights watching fingers being reattached, and not a very challenging anesthetic, but very challenging surgery. So I'll definitely say that Dr. Walshy is a very talented surgeon, but her talents certainly extend beyond the OR. Her research examines variation in patient-reported outcomes across hospitals and surgeons, and she is focused on patient-surgeon hospital level factors that drive variation in care. And she does a lot of work with the opioid epidemic. Certainly, an engaged stakeholder in the opioid crisis is the surgery department. We're sending home patients with opioid prescriptions, and so she's been able to make a huge impact both through a program called MOPEN, which is the Michigan Opioid Prescriber Engagement Network, but she's made a big impact locally, statewide, and nationally in her research studying how surgeons can impact the opioid epidemic. So with that, I'll give the floor over to Dr. Walshy.
Thank you. Thank you so much for the invitation to be here today. It's always great to hang out with you guys, not at 2 o'clock in the morning in the OR. So very glad to be here. I'm going to share a little bit today about Michigan Open. So this is a program that we developed about 2 to 3 years ago when we were trying to come around this concept of what is the role of the surgeon and the anesthesiologist in the opioid epidemic. So here are two of my colleagues, Mike Englesby and Chad Brummett. And so about 2 or 3 years ago, we started exploring this issue. My beginning interest when I first started on faculty was how can patient-reported outcomes be used to leverage surgical quality, and how do we use those metrics to define whether or not we're doing effective surgery or non-effective surgery. Around that time, we started coming around this concept of pain, and can that be measured, and then can that be captured? And from there, we started thinking about questions around opioid management. Several of my colleagues in surgery thought, well, I'm not really sure that surgeons play a role in that. But I think I'll show you some data in a few slides that we prescribe a lot of opioids in this country, and I think together we have an opportunity to really make a difference. So my funding and disclosures are largely related to the generous support from the Michigan Department of Health and Human Services. We're funded as a Medicaid match program, and in addition to the traditional sources of funding, I would really encourage you all to reach out to your state legislators and the Departments of Health and Human Services in each of your states. They've been very responsive to us and have been amazing partners. In addition to Blue Cross Blue Shield, that's the largest payer in our state, and I will allude to their partnership in a few more slides, but I've been blown away by their generosity and their support. Okay, so these slides will look familiar to you, that opioid overdose rates are increasing in our country, and that's certainly no secret, but I will also call your attention to the yellow line there. That's the Midwest sector of the United States where we live, and in the latter quarter of 2017, this rate of opioid overdoses has sharply escalated by about 70%. And statistics released by the CDC in 2017 suggest that we're now up to 174 deaths per day. And when we started looking at this issue, it was around 73 deaths per day. So I think we can all agree that this epidemic doesn't show any signs of slowing down anytime soon. I live in Michigan, which is a bright red state here on this map. We've actually gone in the last year or two from being number 18 in opioid-related overdose deaths now up to number 15. We write for 11 million prescriptions in our state. That exceeds the number of individuals that live in our state. And right now, there's estimates that deaths related to prescription opioids are about twofold higher than deaths related to heroin. The reasons for this are kind of unclear, but probably relate to the prevalence of those substances in our communities. So this next slide is data that was analyzed by Dan Larrick, who's one of our anesthesiology residents at the University of Michigan. And I think it's really telling because it shows from 2010 to 2016 the proportions of prescriptions that were provided by different avenues of care in our country. And you can really see where prescribing guidelines have kind of been targeted. So in dark blue, that's primary care and pain physician and pain medicine. The prescriptions have actually dropped from about 66% to 61%, small but significant decreases. In contrast, prescriptions related to surgical care have increased from 19% to 22% between 2010 and 2016. What's also important is that our prescribing for each individual prescription has also gone up, both in the total OMEs that we prescribe as well as the oral morphine equivalents per day provided in an initial prescription after surgery. This is in contrast to other new prescriptions provided by different subspecialties such as dentistry, emergency medicine, and primary care. So I think if we're going to figure out how to be effective stewards of opioids and how to be part of the solution, particularly as surgeons, it's important for us to reflect back on how we got here. So I'll go through a little bit of what I think the influences of that have been. So you all have probably all seen this paragraph. This is the Porter and Jick paragraph that was published in the New England Journal of Medicine. I started my internship in 2002, and at that time when we would prescribe opioids for people after surgery, we were consistently taught, largely by our chief residents, that it was okay to prescribe whatever because opioids if prescribed for acute pain are not necessarily addictive, and that was true for both oxycodone and OxyContin, so we prescribed quite liberally. This was published by the New England Journal of Medicine last year that shows how often and how often this article was cited and how frequently it was often misrepresented. And these may look familiar to you. I remember seeing these when I was in residency that really highlighted, again, the aggressive marketing campaigns around oxycodone and OxyContin, again, with the thought that they wouldn't be addictive, particularly in the context of procedural care, which is important for this talk. Now, of course, we know differently, and this alludes to the settlement that came out in 2007 by Purdue Pharma. So I get this question all the time. Well, why do surgeons prescribe so much? Why do they consistently send their patients home with 80 pills after a carpal tunnel release? So I think the reasons for that are multifactorial, and we'll explore some of them here. So first and foremost, kind of going back to the slide I talked about before, pain management has not been uniformly taught in surgical residencies. We typically learned how to prescribe opioids after surgery from our chief resident or from the nurses in the call centers to encourage us to prescribe more. They weren't addictive, and if we didn't prescribe enough, it was probably just going to result in more refills. So that has certainly been part of the problem. To understand that, we went back and looked to see, well, how much does opioid prescribing vary across hospitals in Michigan? And I think this lack of education and the lack of prescribing guidelines that we've had has had a huge impact on how much we actually, on the variation that we see in prescribing after surgery. So in some hospitals, and full disclosure, the University of Michigan is way over there on the left. We prescribe on average about 100 tablets after inpatient surgical procedures, but other hospitals in Michigan only prescribe about 20. So this is drawn from insurance claims data, which is powerful in many ways to capture the fill patterns. It does not capture consumption, and it doesn't capture patients who got a prescription but never filled it, but it does provide some eye-opening statistics about the variability and how much people are discharged from the hospital with, particularly when it comes to opioids. Sometimes there are policies and they kind of fall apart due to unintended effects and unanticipated other factors. So for example, right here in 2014, the schedule of hydrocodone changed, meaning that it went from Schedule 3 to Schedule 2. So for us as surgeons, that meant we couldn't prescribe for more than 90 days. In general, surgeons don't tend to prescribe related to days. They tend to prescribe more related around the number of pills that you're going to provide somebody. But importantly, it meant that we couldn't call in prescriptions and we couldn't fax them in and we couldn't provide refills. So we went back and looked, well, what is the effect of this policy? Because all of us had gotten comments back from our clinics, please make sure you prescribe more because you're not going to be able to call it in anymore. We don't want our patients calling for refills. So this is what it looks like when you look back at Blue Cross Blue Shield data. Invariably, the majority of our postoperative prescriptions are hydrocodone. And then thinking back a little bit more in that time, e-prescribing in 2014 was not widely used. Even today, it's only used in about 30% of practices across our state. So what effect did that have? Well, sure enough, when we go back and look at Michigan medicine data from in 2014, there's actually a downward slope in hydrocodone prescribing before that policy. But afterwards, you can start to see the trend go up a little bit. What happened across our state? Basically the same thing. We saw an increase, a sustained increase by about 35 oral morphine equivalents immediately following the policy change in 2014. Unlike other specialties, such as specifically primary care, where they actually saw a decrease in opioid prescribing after this policy, we saw the opposite. There really wasn't any change in the total amount of oral morphine equivalents that were filled after surgery, which equated in this particular cohort to about 43,000 extra pills. And where that had probably the biggest difference, interestingly and unfortunately, is in our opioid-naive patients. These patients tended to be overprescribed opioids more than intermittent users and chronic users, and these are the patients who are going to be more likely to have leftover pills. So I think this particular example highlights a place where if we don't couple policy together with education, specifically in the context of surgical care, this is one example of that, sometimes policy kind of falls short. Other examples of where different factors may influence surgeon prescribing is around patient satisfaction and patient experience. So CMS has a series of surveys called HCAP surveys, and patients complete these when they're discharged from the hospital. And one component of these surveys is around pain management. And so, in fact, a couple of years ago, CMS actually advised that we should use these measures with an abundance of caution because it may perversely incentivize opioid prescribing. One of our fellows went back and looked at that, though, and found that HCAP scores actually weren't associated at all with the amount of opioids someone was discharged with after surgery. And I think that this highlights important evidence that we can potentially drop our prescribing without necessarily at the expense of patient satisfaction or patient experience. And as we were kind of going through this foundational work, we were trying to get at the factors, how are we really going to convince surgeons that they need to prescribe less? Another example of this is refills. We get this all the time from our surgical colleagues. If I prescribe less, again, their patients are going to call for refills. So what does this look like? This is data drawn from insurance claims. This particular data set is Optum. This aggregates insurance claims from United Healthcare. It also provides de-identified provider characteristics and patient characteristics. So it's a single payer, but it's pretty robust because it captures data across all 50 states. So we looked at a cohort of about 26,000 patients who had undergone a combination of inpatient and outpatient surgical procedures. On the x-axis, you can see the number of hydrocodone pills that were provided in the initial prescription, and this was to opioid-naive patients, so we would expect that they probably wouldn't necessarily need to refill. And we asked, what was the probability of refill? I initially was expecting that we would find this beautiful ROC curve, and I would exactly be able to tell you that if you prescribed 14 pills, that someone wouldn't necessarily need to refill. But we didn't see that at all. Actually, what we saw was that it didn't really matter how many pills you sent somebody out with. The probability that they were going to refill was around 6%, which I think suggests that patient factors are probably more important than the amount of pills that we send somebody out with. And I think what it also highlights is, again, another opportunity where we can drop prescribing and not necessarily at the expense of other measures of healthcare utilization. Another reason that I think that surgeons tend to prescribe so much is because they're trying to prescribe for a really heterogeneous group of patients. There's opioid-naive patients, certainly about 40 to 50, sometimes even 60% of the patient population, depending on the condition. About 8 to 10% are chronic opioid users, and probably more harder to detect are the intermittent opioid users, or people who sort of periodically fill prescriptions across the year. And surgeons may or may not be good at asking these questions prior to surgery, and sometimes it doesn't show up on the MAR when we're doing our preoperative H&Ps. This is data led by Paul Hilliard from the Michigan Genomics Initiative, and what it shows is that these preoperative opioid users have an independently higher risk. They tend to present to us at an increased risk for postoperative complications related to tobacco use, the concurrent use of alcohol, substance abuse, depression, anxiety, fibromyalgia, and ASA class. So in general, these patients are at higher risk when they hit the door. And this is work done by one of our medical students, Dave Crone, that shows that these preoperative users do have poor outcomes after surgery. They're more likely to have higher costs of their hospitalization. They tend to have an increased rate of complications, and they tend to be readmitted more frequently, and they tend not to be discharged home. When we think about the fact that there's somewhere between 5 and 10 million patients or individuals currently in our country on long-term opioid therapy, there's about 9 procedures. It's the average number of procedures over a lifetime. That's about 90 million opportunities for us to coordinate, more often uncoordinate care for these preoperative opioid users. And what we've seen, again, in data drawn from Optum, is that this is really common. So whether it's because surgeons just aren't good at screening for these high-risk patients prior to surgery, or that there's some other inherent risk around using opioids is a little bit unclear, but there's no doubt that patients who present to surgery currently using opioids are more likely to have high-risk prescribing, specifically overlapping prescriptions, the concomitant prescription with benzodiazepines, and getting prescriptions from multiple providers. And what this yields is greater readmission rates and complications related to pain and opioid adverse effects. And we've also seen that postoperative complications are higher amongst preoperative users. This is, again, work done by Dave Crone that shows that there's a difference between 6.3 to 8.3%. Small, but a very real difference for our patients who present to us on opioids prior to surgery. And also, interestingly, is that it doesn't necessarily matter how recent the patient has filled opioids. There's some independent effect there, regardless of timing. Also, it's important to consider the patients that go on to new persistent use. And these patients are really hard to identify preoperatively. They didn't fill opioid prescriptions in the year prior to surgery. And the patient risk factors that underscore these patients is really hard to detect. But what we've seen, this is work led by Chad Brummett, published last year, looking at major and minor surgical procedures. The rate is about 6%. Also from that group, the rate for knee and hip arthroplasty is around 8%. For hand surgery, it's around 13%. For patients undergoing spine surgery, it's 13%. For pediatric patients, it's 5%. For cancer patients, it's around 10%. And for some cohorts of breast cancer patients, it's actually up to 20%. Again, these are patients who didn't fill any opioids prior to surgery and then leave the episode of surgical care, continuing to fill prescriptions for months after their surgical care would otherwise be considered complete. Work by one of our research fellows has now recently shown that this is true after wisdom tooth extraction. And where I think that this is important is we have randomized controlled trial evidence that shows that opioids aren't necessarily any better at controlling post-procedural pain for patients who are undergoing wisdom tooth extraction, and about 80% of these patients filled a prescription for an opioid. The rate of new persistent use is about 2%. So I think particularly as a surgeon who tends to see patients for, on average, probably about 2 to 3 months after doing a surgical procedure. What happens then to these patients who suffer from new persistent use? This is another one of our research fellows, Jay Lee, who looked at their trajectory. And for patients who develop new persistent use after surgery, they go on to fill about 6 tablets of Norco per day, up to about 6 months after surgery, which, when we go back and look at our chronic users, that's about where they fall, kind of right in the middle. And more telling, who ends up prescribing for these patients? So invariably, this ends up falling back on our colleagues in primary care and medical subspecialties. And the cost of this is not insignificant. So for patients who develop new persistent opioid use after inpatient and outpatient surgery, that yields an excess cost of about $8,000 and $2,000 respectively. And it's compounded when patients develop surgical complications, so about a $20,000 or a $10,000 increase in expenditures, which, if you do some fast math in our state, in Michigan, that's about $466 million per year in extra expenditures just related to new persistent opioid use alone. So with this evidence that we developed, we wanted to ask, well, can we actually convince surgeons to improve their prescribing? Do we have an opportunity here to do that? And I think the answer is, of course, yes. And we've gotten to see pockets of a lot of this work in different places and different institutions. So I'll share with you one of the examples that we have from the University of Michigan. And why I think this is really important is because although we started with work around the chronic opioid user, invariably, probably the part where we contribute the most as surgeons is in our excess prescribing. And those pills end up flooding the communities and are clearly the gateway to later substance abuse. So we've really shifted towards a preventive model with respect to the opioid epidemic and thinking about this. And here's an example of how we can make a difference. So if you think about laparoscopic cholecystectomy, one of the most common procedures performed in the United States, one of our medical students went back and looked to see, well, on average, how many opioids were patients prescribed after this procedure? And it's interesting. Some people were only given around 8 to 10 pills. Some people were given 120 pills. And about 77% of prescriptions somewhere fell in around this kind of 50 pill range here. And then Ryan went back and called all of the patients to find out, well, how much did they actually take? And you can see the curve clearly shifts and is not in the range where we tended to prescribe at all. And on average, people took around 5 to 10 pills after this procedure. So Ryan came up with some really simple guidelines: 15 tablets of oxycodone, 15 tablets of Norco, and probably even more importantly, coupling it with Tylenol, Motrin, and patient education. And he delivered this as a single educational intervention in November of 2016. And here's what prescribing looked like before. It was widely variable, and it was, in general, in excess. And afterwards, it dropped. It narrowed, the variation narrowed substantially, and I think what's really important about this slide is that the drops was sustained even through August of 2017. And if you think about all of us that work in an academic institution, this reflects the number of prescribers that turn over on that service every single month. We didn't see a jump in that, and it reflects the change in the influx in a new group of interns and residents that came in July. It didn't jump up after that either, which I think highlights the important opportunity we have within the culture around us that we can inform each other's prescribing and have a sustained effect. So with this single intervention, this was a 370 patient cohort. If you think about the fact that we dropped our prescribing by about 30 pills per patient, that was about 13,000 pills that Ryan was able to keep out of our communities just from lap chole alone. And this aligns with other data. This was published by Hill in 2016 from Dartmouth, again showing that about 70% of the pills that we prescribe as surgeons go unused. If you think about just in Michigan that we prescribe maybe about 30 extra pills per prescription, and we do somewhere around 1.9 million operations, that's about 62 million pills that go unused in our communities alone just from our excess surgical prescribing, again, because we haven't had guidelines and it's been widely variable. That would fill up all of our stadium and 2/3 of Yost Ice Arena. And so getting back to these factors, what motivates surgeons to prescribe and what is going to be the barriers and roadblocks for them to change their prescribing, we went back and asked what was the refill rates, what were patient-related pain scores, and we found, again, there's no change in the calls for refills. There weren't any changes in patient-reported pain scores after laparoscopic cholecystectomy. And interestingly, patients actually consumed fewer pills when we wrote smaller prescriptions. We see the flip side of this effect in fast food marketing in this particular example, but I think it highlights an opportunity for us to really change the way patients think about pain when they enter the preoperative period and change our culture about how to manage pain. Also, what's interesting to think about is the spillover effects just from this single educational intervention. This was all designed around laparoscopic cholecystectomy, but it clearly prompted prescribers, at least at our institution, to think critically about their prescribing for other conditions. So, for example, a sleeve gastrectomy, an appendectomy, an inguinal hernia repair, and a thyroidectomy. We saw drops in prescribing for each of these procedures as well. So, Mike, Chad, and I are obviously in an academic institution. We're in academic practice, and we all spend a lot of time doing research and thinking about data sets and thinking about manuscripts and grants and all that kind of stuff. But I think where this partnership has really changed my thinking about this is how we can make impact in our communities, and specifically how we can partner with other groups, because this problem, as you're going to hear from all the panel, is so complex. There's no way that an individual surgeon or an individual anesthesiologist or an individual epidemiologist is going to be able to fix this. So instead, how can we come together and make the broadest impact? So I'll highlight here the CQI programs in our state. So in Michigan, Blue Cross Blue Shield, again, as I alluded to, is our largest payer. And so what they've developed over the last 10 to 15 years is a network and partnership across hospitals to essentially pay for participation in hospitals' feedback outcomes, then come together in quarterly meetings and decide on the aspects of surgical quality that they want to target and improve. And what that gives us is a powerful framework that we can develop best practices around and then make statewide change. And why that's important, I think, is because I am a hand surgeon. And so if I go to talk to cardiac surgeons, they're not going to listen to me about prescribing recommendations. They want to hear it from their patient population and from people that are in their clinical space. Similarly for those of us in hand surgery, those of us in general surgery, et cetera, et cetera. So it's really important that we're able to engage all of these different prescriber and provider groups. And if you overlay all of the hospitals that participate in these networks, they overlay very nicely with the opioid mortality map that's in our state. Again, highlighting an opportunity where I think we can make a real difference in our communities. And these are our partners. So there's Chad in the blue shirt, Mike Englesby, who's a transplant surgeon at Michigan, next to me. Chris Priest is the former deputy director of the Michigan Medicaid program in the Department of Health and Human Services, who helps sponsor our program. We meet with these individuals regularly. We have calls every other week with them. They've been incredible partners. And then Tom Lydon from Blue Cross Blue Shield is on the far left. And this again highlights the programs that are in Michigan. Again, the importance of really being attuned to the clinical condition that we're trying to develop best practices around. We're housed here at IHPI. And I think, in addition to research and writing papers, one of the most important things we can do in our communities is figure out ways that we can create convenient ways for patients to dispose of their opioids after surgery. We've clearly demonstrated that we prescribe a lot. And I would say right now that patients' access to disposing opioids is largely limited to law enforcement agencies. And particularly for our patients who are struggling to drive after surgery, they're still in pain, they're dependent on their loved ones for care. This can be really challenging. Chad Brummett has spearheaded this entire effort. The first one was several years ago in Ann Arbor, and we had one back in September of 30th. We actually partnered with around 7 to 8 sites around our state. And these are the statistics. We had 766 people visit this event, just this single event. We took back 900 pills. 17,500 of those were opioid pills. The oldest opioid from all the events is from 1976, and the most common reason people bring back opioids is leftover pills from surgery. So again, Chad's developed a very powerful resource for us to be able to understand what are the effects of our overprescribing in our communities, as well as doing a tremendous community service. And in fact, right now, it may actually be wrapping up. We're having a take-back event back in Michigan now with 27 sites. Again, leveraging our structure across our CQI programs in our state to make a difference in all of our communities. These are a single event, though, throughout the year. We host them twice a year, but what do patients do kind of on a daily basis? So in our program, we've assembled a team of students. They essentially update a take-back map every single day because there's differences in each site with respect to whether they can take back liquids or patches or pills, and this allows us to give our patients real-time information at the time of discharge about where they can take their medications back. I also think a really important arm of our work is taking our data that we've gathered and this evidence and using it as an avenue for advocacy and to inform policy, because I think specifically the hydrocodone example illustrates a place where policy is largely designed to encompass all aspects of care, but it may not necessarily be attuned to the nuances of surgical and perioperative care. And without coupling it with appropriate patient and provider information, sometimes things can fall apart. I think that's a place where we can be really useful to go back to our legislators and our policymakers to try to help inform this. This is going to be critically important coming up because about 26 states already have instituted prescribing limits. Most of these are around 5 to 7 days. Some are as short as 3 to 4 days. In Michigan, specifically, this is going to be limiting prescribing of opioids for acute pain to about 7 days. But again, I think sometimes this policy may not necessarily be attuned to how we think about prescribing in the context of surgical care. Because if you think about the signature for this prescription, if I wrote for 1 to 2 pills every 4 to 6 hours as needed for pain for 7 days, I can still prescribe up to 84 pills. And you can see from the prior example that patients certainly take far less. Here's again highlighting this. There's a sustained increase in this in opioid prescribing when it's not coupled with education, yielding 43,000 extra pills. So where can we do things better? So here's an example from MSQC. So we actually went to the MSQC program. This targets general surgery and vascular surgery procedures, and they touch about 72 hospitals in our state. We collected data from patients to try to inform prescribing guidelines. We looked at consumption and we looked at prescribing. And again, you'll see similar gaps to what we saw for laparoscopic cholecystectomy. We prescribed far more than our patients consume. So we developed these guidelines. We've actually implemented them across the state. They went live in October of this year. And these are the revisions now because we have an opportunity to continually collect data from patients. We can actually push these prescribing recommendations lower by about 20 to 25% in the last iteration. We've been able to partner with Blue Cross Blue Shield to find ways to incentivize providers to have these important conversations around pain management and pain expectations. In July of 2018, this will actually be included as a modifier 22. That means is there will be enhanced fees by about 35% for patients who are able to undergo these surgical procedures with basically opioid-sparing postoperative prescribing. I think another important opportunity is the opportunity for shared decision making. So now in our state, we have the opportunity for partial fills. We've developed instruments that we can use at the bedside to counsel patients around prescribing, which also highlights policy that's been put in place around informed consent for the risks of prescribing an opioid, specifically the dangers of addiction, proper disposal, the delivery of a controlled substance is a felony if not under the constraints of prescribing, and for pregnant and female patients. And we have to be able to document this. So what have we been able to do around that? So we came together with individuals in our communications department and developed some patient materials that highlight this, that are all on our website. And health systems can now brand these for their own use. We make these all publicly available. We give them to our patients after surgery. And we've also got links back to our disposal resources. So I think all of this work highlights an opportunity where not just health services researchers, but when we collaborate with individuals from social work, primary care, education, public health, public policy, psychology, and statistics, we can come together and make a difference so that we don't just write another paper, but we do something that will really impact our patients daily. So this is our team, and I'm happy to answer any questions. Thank you.
Thanks for that great talk about all the amazing stuff happening in Michigan. We're going to switch gears a little bit, so I'm going to introduce our next speaker. His name is Giancarlo Vanini. He is an assistant professor in the Department of Anesthesiology and a faculty member in the Neuroscience Graduate Program at the University of Michigan. He did his undergraduate and medical training in Uruguay, And then he came to Michigan to do a postdoctoral fellowship where he became interested in studying the neurobiology of arousal states. So he uses a systems neuroscience approach to study the mechanisms controlling interacting states of sleep, anesthesia, and the development of chronic pain. He'll be telling us a little bit more about the potential role of caffeine to alleviate post-op pain in sleep-deprived rats and hopefully sleep-deprived residents and attendings as well. So please join me in welcoming Dr. Vanini.
Very good. Can you hear? Yes, okay. Let me find my presentation. There we go. Good. Yes. Well, thank you very much for the very nice and accurate introduction. I don't have a lot left to say about myself. I do need to say that my current work doesn't involve any opioids, but the potential implications of the work that I'm going to present and the exciting future directions are very relevant to today's topic. I must state that I do not have any conflicts of interest. And just in case, having heard about my career path, in case you're wondering why, that's a question that I find myself asking almost on a daily basis, and there's no short answer for that. I guess I could say it was an accident, but I really became very fascinated by the brain, and I was fortunate enough to come across the right people at the right times to help me transition from a trainee into becoming an independent neuroscientist. To provide some context for my work, I will remind you that sleep and pain have bidirectional interactions. There is abundant preclinical and clinical evidence showing that sleep disruption enhances pain perception. And you also know from your own clinical experience that pain and pain meds such as opioids disrupt sleep. Now, why is that clinically relevant? Sleep disruption and pain are highly prevalent. Some say that insufficient sleep is reaching epidemic proportions in all the Western world. They are frequently associated and together contribute to increased morbidity and mortality. Furthermore, there's also evidence showing that altered sleep after trauma or surgery is a potential risk factor for the development of chronic pain. This, let me see if I can, yeah, good. This very nice meta-analysis concluded that insomnia symptoms are a reliable predictor of new chronic pain onset. However, there are two major questions pending, and those are what are the mechanisms by which sleep disruption enhances pain, and one of the problems is that the majority of the studies have focused on peripheral mechanisms as well as spinal mechanisms, and we know very little about supraspinal mechanisms that might be involved in this phenomenon. The second question is whether disrupted sleep can causally contribute to chronic pain. There is some emerging data from my laboratory and others. We are just starting to scratch the surface, and we are now transitioning and focusing on the how, which is a major task. So to start addressing these two questions, we came up with a number of experiments, the first of which tested the hypothesis that sleep deprivation, in this case prior to surgery, contributes to chronic pain, to postoperative pain. So that's the The timeline for these studies, the experimental design was very simple. A group of rats that was sleep deprived for 6 hours. Another one was allowed to sleep as needed for those 6 hours. After that, they were deeply anesthetized. We collected some blood samples for quantitative assessment of stress markers. And we created this surgical pain model following published guidelines by Tim Brennan and his colleagues in this early paper in 1996. After recovery from surgery, then pain testing began and continued daily for the next 6 days after surgery. For the assessment of mechanical hypersensitivity or postoperative pain, we used the von Frey test, which is basically same as in humans. We use a set of calibrated filaments to determine the threshold to mechanical stimulation in the skin around the incisional area. This is a very standard test for quantification of pain in this rodent model of surgical pain. And what we found was that sleep deprivation before surgery made everything worse. The graphs to the left show the time course of the changes in the mechanical threshold in males and females. The graphs to the right show the group means for all conditions. These are pain thresholds collapsed across time during postoperative days 1 through 6. So as you can see here, sleep deprivation caused a longer duration of postoperative mechanical hypersensitivity and in all cases increased pain levels after surgery. That's relative to control groups. I want to bring to your attention that this is not a model of chronic pain, but the effect of sleep deprivation was substantial, and in all cases, the duration of this postoperative hypersensitivity was twice as long in the sleep-deprived animals relative to controls. We found no significant change in stress markers, corticosterone and ACTH levels in males and females, suggesting that the increase in pain, in postoperative pain, in these animals was not related to a stress response caused by the sleep perturbation. This was not news to us. There are quite a few papers showing that prior sleep that determines subsequent pain, and in this case, all taken from basic science studies. This was true for a model of neuropathic pain, a model of diffuse musculoskeletal pain, which is something like a fibromyalgia-like model, a model of inflammatory pain, and the same post-operative pain model. The main difference between this study and ours was that they used selective rapid eye movement sleep deprivation, the dream sleep state. And they found that the resulting pain phenotype was mainly caused by the stress response associated with REM sleep deprivation. So the second question was whether there was a relatively simple way, an easy way to counteract the effect of sleep deprivation, the effect of sleep deprivation on postoperative pain. And we chose caffeine because, as you all know, is a non-selective adenosine receptor antagonist, and we know that brain adenosine levels gradually increase during periods of extended wakefulness or sleep deprivation. So the timeline for these experiments is virtually the same as the one I showed before, except that in this case we gave preemptively gave an AP injection of caffeine or vehicle. So the schematic representation here shows what we did with these animals. This is a representation of the experimental design. So animals were given vehicle or caffeine, were allowed to sleep, or were kept awake for 6 hours, and then they had surgery. And what we found was that sleep-deprived animals had a duration of 4 to 5 days, or sorry, the postoperative hypersensitivity had a duration of 4 to 5 days in the sleep-deprived group. But when animals that were also sleep-deprived were preemptively treated with caffeine, the duration was just 2 days, just half the time relative to the sleep-deprived animals. The overall intensity of postoperative hypersensitivity was also lower in caffeine-treated animals. When we gave caffeine to animals that were allowed to behave and sleep as needed, post-caffeine injection, that didn't cause any additional benefits relative to controls. So that indicates that caffeine might only be helpful in those animals that were sleep deprived, and this has important mechanistic implications. The clinical implications of this study are yet to be tested, and we are starting to work towards that with my colleagues in the department. I will talk about that in a few minutes. Okay, so the next question was, where is the site of action for caffeine? And there are many potential mechanisms likely operating in parallel. They are not mutually exclusive. And we chose to target the median preoptic nucleus, which is a very tiny nucleus deep in the rostral hypothalamus, because this nucleus is one of those keynotes that is important for sleep regulation. It has sleep-promoting neurons. Those neurons are activated by adenosine, and also we know that neurons in the median preoptic nucleus project to many sleep and pain-related nuclei, some of which are represented here. This is a sagittal view of the schematic sagittal view of the rat brain. The median preoptic nucleus would be around here, and some of the downstream areas of interest are the peripheral region of the hypothalamus that contains hypercholinergic / orexinergic neurons, the ventrolateral division of the periaqueductal gray, and the ventral pontine reticular formation. All of them have in common that they all participate in the regulation of sleep and wakefulness, and they also modulate pain. And their projections, at least part of them, converge into this area of the caudal brainstem called rostral ventromedial medulla. It's I will call it RVM from now on. Neurons in the RVM project to the spinal cord and modulate the influx of nociceptive information at this level, either facilitating or inhibiting nociceptive, the flow of nociceptive information. So we hypothesized that adenosine levels that increase in many brain areas, but especially in the preoptic region of the hypothalamus, then adenosine activates some of these projection neurons and sort of functionally scramble these circuits, causing net pain facilitation. So if this hypothesis is correct, then one way we could test it was very simple, injecting an adenosine receptor antagonist into this brain area and test if that would help reduce the increase in pain caused by sleep deprivation in our model. So I'm going to go fast through this timeline. The main difference here is that rats for this study were surgically implanted with guide tubes for drug delivery into the brain, into the preoptic region. Then you know the rest of the stories, and the rest of the design is schematized here. This is the drug used, ZM241385, which is an adenosine A2A receptor antagonist. So we injected these animals with this adenosine antagonist or vehicle. Animals were sleep deprived or allowed to do whatever they needed to do with their sleep during 6 hours, and then they had surgery. What we found here was, again, that the sleep-deprived group showed the same duration of postoperative mechanical hypersensitivity as in all the rest of the studies. This was very consistent across all the experiments, across all the experimental groups. And when we pre-treated a group of animals with the adenosine antagonist injected into the preoptic region, we saw that the duration went from 4 days. These were also sleep deprived, by the way. The duration went from 4 days to 2 days. So again, we were able to block the increase in postoperative sensitivity induced by sleep deprivation. The overall levels are clearly shown here, how the pretreatment with the antagonist reduced the intensity of those pain behaviors. Similar to caffeine, when we injected this antagonist into non-sleep deprived animals, it didn't add any benefit to it, suggesting also that sleep deprivation and an increase in adenosine levels is a prerequisite for this drug to be effective. So next I'm going to show you, this is a recap of the results shown thus far. And this is in a very simple, non-quantitative way. We found that relative to controls, sleep deprivation increased the duration of mechanical hypersensitivity during the postoperative period, and that systemic injection of caffeine or intracerebral injection of the adenosine receptor antagonist into the preoptic region of sleep-deprived animals helped to block the increase in the duration of this postoperative hypersensitivity, in both cases approaching control levels. So the last group of experiments was designed to test if injecting this adenosine receptor antagonist into the preoptic region would also be effective in preventing the development of pain hypersensitivity in non-operated animals, just intact, pain-free animals. So these animals were again implanted with cannulae to deliver this drug into the preoptic region. So drug versus control, vehicle solution, sleep deprivation or no sleep deprivation, and we assessed the effect of sleep deprivation and the drug treatment with a method to test for thermal hypersensitivity, hyperalgesia. Yeah, I'm good with time. So this graph plots the latencies to PO withdrawal away from the thermal stimulus. This is a noxious stimulus, and the data are normalized relative to each animal's baseline. And what we see here in red is that in both cases, with the average and the time course, sleep deprivation caused a consistent decrease in the latencies, indicating that the animals became hypersensitive to pain. This is well known and has been published elsewhere by us and others. When we injected the adenosine receptor antagonist into the brain of animals that then underwent sleep deprivation, this drug blocked the development of this thermal hyperalgesia, indicating that this is a potential mechanism for this sleep, for mediating the sleep-pain interaction. To conclude, we saw that a brief perturbation prior to surgery worsened surgical pain. The increase in surgical pain was not associated with stress or the stress response induced by sleep deprivation. Systemic caffeine and intra-hypothalamic injection of the adenosine receptor antagonist blocked the increase in pain caused by sleep deprivation. Altogether, this suggests that adenosine A2A receptors in the median preoptic may contribute to regulate sleep-pain interactions. If there are two important things to take away from this talk is that preoperative sleep management is really important. And this is not just based on my work. There are several human studies indicating that this is the case, and that caffeine, if proven to be effective in humans, in patients, may help to reduce pain and reduce opioid use in post-operative patients. What's next? So we're working on part of that and many more questions, but we are pairing up with some of our colleagues on the clinical side to translate these findings, and I can't emphasize how important it is a fluid communication between the basic scientists and clinicians to do this translation from the bench to patients and back. I'm very fortunate to be part of this very nice group with diverse collaborators that make this easy and enjoyable, really. The second goal is the characterization of preoptic neurons and downstream targets that mediate sleep-pain interactions and the effect of caffeine. To this end, we are using viral vectors for site-specific deletion of adenosine receptors, tracing pathways, and also for receptor expression in subsets of neurons of interest that we can then manipulate at will and test our working hypotheses. Before I leave you, I'm going to acknowledge and thank my funding sources and my amazing research team. Vivian and Angela were both instrumental in the study that I presented today. We have a good number of very talented students also, and these are some of my collaborators who, part of them are those that I was referring to when I mentioned the right people in the right time to help me in the transition to become an independent investigator. So as you can see, we have clinicians and we have basic scientists here. So it's it's a very nice group. Thank you very much. I'll leave you here, and I'll be happy to answer questions at the end. Thank you.
Thank you, Dr. Vanini. We have one more speaker. So Dr. Afton Hassett is a licensed clinical psychologist and an associate research scientist in the Department of Anesthesiology, again at the University of Michigan. She's the PI, a PI at the University of Michigan's Chronic Pain and Fatigue Research Center, and her research focuses on evaluating predictors of opioid use and persistence, as well as the development of relaxation-based and resilience-enhancing activities to promote improved pain, self-management, and a decreased need for opioids. So Dr. Hassett's NIH-funded. She has over 80 peer-reviewed articles, and she's a leader in the field of resilience and pain. She'll be talking about the use of self-management strategies to reduce anxiety and pain in the perioperative setting. So please join me in welcoming Dr. Hassett.
All right, thank you so much for having me. While I figure out my slides, can I get everybody to stand up and stretch? It's 3 o'clock in the afternoon. Yes, a quick stretch. Wonderful. Okay, let's see if I can. I'm a Mac user, so this might take me a minute. Yeah. Where's the mouse? Okay. Mouse. Mike. Come here. Come here. You can sit anytime. Okay.
It's on 2 screens. So
Okay.
just got to bring it back over.
Oh, there.
Here, we'll close out of this one. It was on that screen, so let me slide over. Which one's yours?
Okay. I am resilience.
All right, let's get that one.
There you go.
open.
Great.
Perfect. We'll start. And you're
Excellent.
good to go.
Great. Is it going? There we go. All right. Thank you so much for inviting me to be here and to talk to you a little bit about resilience. These are my disclosures. And I was also asked to talk a little bit about my team and kind of where I come from. And it was, as was mentioned, I'm a psychologist. I work at the Chronic Pain and Fatigue Research Center along with a physician, another psychologist, and 2 neuroscientists. But that doesn't get at half of our team. Our team is many physicians, surgeons, nurses, OTs, PTs. We even have medical assistants delivering our interventions. We have engineers, we have imaging people. It just kind of pays to speak to everybody that you can and tell them about your interests in research. And it's amazing who knows somebody else who has that same interest, and you start to make these webs. But within our team, I'm kind of the E for emotions, so I really focus on emotions and pain. And as psychologists, we've done a dandy job looking at depression and anxiety and all these other negative emotions. Anger, helplessness, pessimism, these are all important things. And yes, we study them, and we do know that they're highly associated with everything that we don't want to see in our pain outcomes, such as hyperalgesia, greater use of pain medication, worse analgesia, longer hospital stays, et cetera, et cetera. So it's important to think about these things. And back in 2009, Ip and colleagues did a really nice systematic review of numbers of studies looking at a particular predictive factor for postoperative pain. And they found anxiety and psychological distress to be way at the forefront of what might be predicting these poor outcomes. And these psychological factors were also very well studied and really likely to be predictive of postoperative analgesic consumption. So these are important factors, as is pain catastrophizing. If you've not heard of this term, it refers to kind of this anxious pessimism about your ability to control pain, or you're just anticipating the worst possible outcome would occur. And this pain catastrophizing is associated with pain following breast cancer surgery and elective surgery, as well as lumbar fusion and ENT. It's even associated with pain following post knee arthroplasty immediately, but also at 2 years. So these are really powerful constructs to consider. In a meta-analysis of 29 studies looking at anxiety and pain catastrophizing, pretty much across the board, these 2 factors were associated with chronic post-surgical pain. And in about 67% of the studies in musculoskeletal surgery, these factors were highly predictive of poor outcomes, and pain catastrophizing might even be one of the best. So these are important factors, and we don't want to poo-poo them, but we as human beings are much, much more than negative factors. We're much, much more than depression and anxiety. We have the ability to be quite resilient, and that's what I study. So I study kind of the opposite end of the coin, and I'm interested in crazy things like happiness and love and calm and enthusiasm. My other psychologists kind of shun me sometimes, but it's okay. These are really interesting and important topics to look at. These are because the science is behind them. When we look at positive affect in a series of studies looking at prospective and experimental outcomes, positive emotions, positive affective states are highly, highly predictive of all the outcomes we do want to see, including lower levels of pain medication, less postoperative pain, greater times walking, post-surgery, and length of stay reduction. And even emotions, really intense emotions like laughter, have really strong physiological effects. In this study here looking at Duchenne laughter, which is laughter that comes from your gut. You know, we have kind of the ha ha ha, I'm laughing because I'm polite. And other times we just like think we might pass out because we're laughing so hard. That's Duchenne laughter, that's from the gut. That has really strong physiological and biological correlates. There might even be kind of an endorphin-mediated opioid effect when we laugh that hard. So that has been shown to be associated with greater pain thresholds. So you might ask me, what underlies the magic? What is it with positive emotions? You know, what do we understand about these things, and how might they be really useful? So probably the best theory looking at positive emotions came from Barbara Fredrickson when she was at the University of Michigan before she moved. And she came up with the broaden and build theory. And what she proposed was that experiences of positive emotions broaden people's momentary thought-action repertoires. It just gives us more options. This in turn serves to build enduring personal resources, ranging from physical, intellectual resources to social and psychological resources. So what she's saying is that negative emotions serve really important survival functions. Fear and anxiety makes us tighten our focus, right? So when we're anxious and we're focused, we're seeing that tiger in the weeds, right? But positive emotions, and on experimental studies, show us that we actually lift up and we have a broader view. You can actually see more in your periphery when you have positive emotions on board. So positive emotions just kind of broaden our options for thought and action. It makes our thought more creative and flexible and integrative. The positive emotions also undo the lingering effects of negative emotions because we are combinations of both types of emotions. And the types of effects that positive emotions undo are kind of the negative physiological effects often that come with negative emotions. And positive emotions can help us build resiliency for later. When we're positive, we tend to bounce back because adversity does happen. Bad things happen. Bad things happen to good people, and we need to be able to bounce back. And also positive emotions draw people to us. When you're smiling, when you're laughing, when you're warm, when you're kind, people come to you, and that becomes your social support, and that's one of the best forms of resilience that we can develop. So positive emotions are associated with all the outcomes we hope to achieve. We can build resilience, though, possibly in our surgical patients by putting in some of these principles in our perioperative settings. So how do we do this? So one notion is prehabilitation. And this is the idea that engaging surgical patients in activities that better prepare them for surgery, including physical therapy, activities such as walking, improving sleep, nutrition, breathing exercises, relaxation, all of these before surgery can help decrease anxiety and pain catastrophizing. Remember, those are the predictors of bad stuff? What we have at the University of Michigan is a really lovely, scalable online program called MSHOP, which stands for the Michigan Surgical Health and Optimization Program. And what we tell the patients is like athletes training for an event. Surgical patients can train for surgery. And the patients who enroll in this program are encouraged to stop smoking. They're encouraged to eat better, to sleep better, to exercise a little bit more, to relax, and to even do some PT, kind of pre-PT exercises and practice on the inspirometers. So our patients go in more prepared for surgery, the surgical process, but also psychologically, having a sense that they have some mastery or some say or an ability within surgery. And Dr. Englesby and his team has shown about a 31% reduction in duration of stay in patients who undergo the MSHOT program and about 28% lower total costs. These are self-directed programs predominantly for patients. So resilience that is kind of beyond rehabilitation is actually even more accessible. We call these kind of positive activities or positive activity interventions. These little gems don't require a lot of specialized training. You don't need psychologists to deliver them. They can be provided just by any healthcare workers or provided online. They don't really need a fancy delivery system. They can be on pieces of paper. That's how we frequently do this. And what we have learned as psychologists, and I think maybe just observers of humanity, that people do what's fun. Right? You got a whole list of things that you got to do on a Sunday afternoon. What's the first thing you do? Probably the fun thing, right? It's just human nature. We do what's fun. So positive activity interventions are many, many things. This is just a list of the most interventions with the most evidence behind them. And the first few I'm going to share a little bit more with you to tell you a little bit more about some of these interventions. I'm really glad to share these with you in electronic versions and paper versions if this is something you want to learn about. But I also want you to consider these for yourselves. These are not just great for patients, but these are great stress management strategies and positive affect building and resilience strategies for busy professionals. So let's talk about a few of these. So the first is pleasant activity scheduling. This is part of cognitive behavioral therapy, and this is the part we can always get our patients to do because it's fun. What we tell patients is 3 to 5 days a week, set aside time to do something that you really enjoy. Put it on your calendar, put it on your iPhone, treat it with the same respect as you would a doctor's appointment or some other non-miss appointment. You can pick simple things like having a cup of coffee with a friend or taking the dog for a walk, but we encourage people to spend time doing your hobby or your sport or take up a cooking class or a yoga class or binge watch a show, but do something that you enjoy. Often when patients are sick, they do only the things that they have to do, and they give up the things that mean the most in their lives, their valued life activities. So pleasant activity scheduling gets people doing a little bit more of this. Another thing, and actually my students, I teach undergrads too, they say this is it. This is the most life-changing thing that they do during the time that we have together. It's keeping a gratitude diary. Has anybody done that? Has anybody done this before? Yeah, some show of hands. It can be really, really powerful. The way that we tell people to do this is write down 3 things every evening for which you are grateful. Kind of think through the day, what was meaningful to you, and write these things down. Make a commitment to do it every single day, every single night for a 30-day period or however long you want to do it. But these 3 things must be different every day. So by about day 7, you are really looking for things to be grateful for, right? You've already covered the kids, the family, the dog, your job. And you start really looking at and appreciating the little things, the sunset, a raindrop, a flower, a hug from a friend, right? These are the things that really enrich your life when you're aware of them. When you stop scanning for the tigers and start looking at the waterfalls, becoming more aware of the beautiful things out there. Another really cool thing is signature strengths. Identify what someone's signature strengths are. We all have them. There's many of them. There are a series of 6 virtues in the navy blue and a whole bunch of little strengths off to the right here. Again, I'm glad to share my slides with you if you want to see. And what we do is we encourage people to identify their signature strengths by completing a questionnaire or in a website. I'm going to show you in a sec, so you guys can do this too. But we tell them to identify their signature strengths and use these strengths, at least the top 7 of them, in different ways, right? So if one of your strengths is creativity and you typically are pretty artistic, use it in a new way. How would you use creativity in the ORs? Right? So how do you use these things that are inherent in you and make you strong in new ways to make you even more powerful? And this is the cool website where you can actually get your strengths done. This is a nonprofit organization that allows you to log in here. They do keep all your data, and I don't know what all they do with it, but basically they do report regularly about the different character strengths across the world. This is a worldwide effort to understand more about, the people in Czechoslovakia have value the same character strengths we do here. But it'll spit out a report for you, and it'll tell you what your strengths are and also what your non-strengths are. So it's a really kind of neat thing to know. We encourage our patients to become more mindful. And a great way to teach mindfulness is through savoring. Again, those of us who are busy eat our meals probably like this and run. One of the best ways to learn savoring is just to eat something really slowly, a piece of chocolate, really enjoy it, have a sense of it. And what we tell people is to consider a typical weekday. Review your morning routine, your daily activities, and your evening rituals, and consider how much time you spend noticing and enjoying the pleasures of the day, both small and large. Every day for the next week, make sure you savor at least 2 experiences. For example, savor your morning coffee or the sun on your face as you walk to your car. Spend at least 2 or 3 minutes savoring an experience. And I challenge all of you, at some point today, just savor something. And if it's really, really special to you, tell yourself, take a mind picture. If you mindfully say, remember this moment, and remember what you smell, what you feel, who you're with, what you feel like, that memory will stick with you. The more of these positive memories we can load away, the more it tends to color our mood, just like traumatic memories tend to color our mood in negative ways. Another great thing to do, another one that's fun to do, scatter out, acts of kindness. Spend one day doing 5 acts of kindness. Somehow this is the magic combination. We've been studying this for years, but doing 5 intentional acts of kindness in one day, they can be really small things or big things. Don't expect anything from the person. Often people will look at you weird. If you buy somebody a cup of coffee behind you at Starbucks, they're often a little shocky and trying to figure out why you're being so creepy. But often a few minutes later, they think, oh my gosh, that was so cool. And frequently they'll buy the person behind them a cup of coffee, right? So kindness has a way of spreading like a ripple. So the more we put out there, the more we get back. But who benefits is the giver of kindness. We're the ones that physiologically and psychologically benefit so greatly from doing kind acts. And I'm going to conclude by telling you about a couple of things that we have ongoing. I've developed an intervention that was kind of a child of need. The thought was like, can we develop an intervention that we could do maybe surgically or for patients undergoing medical procedures, but no psychologists. We don't want any people involved, so something we can just give them, something that, will teach them to be positive and look at positive things, and something that's fun and easy so we don't freak them out, and some way that they'll remember to do this. And so we put our heads together and we came up with this thing called the Positive Piggy Bank. And so what we do is we start off with our patients. We have a bunch of pigs. I mean, we literally have like 50 pigs. And we tell the patient, pick a pig. And they get a piggy bank, and they get a little card that is laminated. They get a bunch of little pieces of paper. And what it says on the laminated card is, every evening think about the people, things, or events that made you happy that day. You may make a list if you like. Pick one of these and spend a moment savoring it. What made it so special to you? Now write down this moment on a currency slip, a little piece of paper. Use enough detail that you can immediately recall what happened. Next, add a date, fold up your happy memory currency, and drop it into the piggy bank. You will make these happy memory deposits in the same manner every evening for the next 30 days. And then we eventually tell them, at the end of 30 days, you'll close your account. This means that you will withdraw all the currency from your piggy bank and read each and every one of these deposited happy memory slips. As you read them, try and recall the details of the happy event and what made it so special to you, and enjoy. So what we do is we've been testing this in healthy, happy people to see if it makes them happier. We've tested in breast cancer, which I'm going to tell you about, and we're just getting the results in a spine pain cohort. And what we're seeing so far are some effects for lowering negative affect, depression, and anxiety. We're seeing lower levels of fatigue, hints about lower pain, improved subjective well-being, and significant life satisfaction improvement. So the little mini pilot that we did on the surgical setting was in women undergoing breast cancer surgery. These women were 18 and older, English speaking, gave consent, and we did a bunch of questionnaires, and then we randomized them to do the piggy bank thing, just 10 patients and 10 patients not. And then we did questionnaires afterwards, and then we did questionnaires again at 14 days just to see if this was agreeable, if we could see any signal. And sure enough, with this particular intervention, we called them the night before surgery and said, okay, open up your piggy bank. And so they opened the piggy bank, and what we saw was pretty cool. The red line is the control group, the blue line is the intervention group. 1 is baseline, 2 is the morning of surgery. And we see negative affect, this is depression and anxiety greatly decreased in the piggy bank group. And at 14 days, the decrease kind of stayed there nicely. And then we saw a really nice decrease in fatigue, which is interesting. But it makes sense to us because positive activities are activating. They tend to make people just do stuff. So that was kind of exciting. And then lastly, we're really kind of having fun too with virtual reality environment. I'm working with Melissa Bauer and some other phenomenal folks within the University of Michigan Department of Anesthesiology. And we tested this underwater virtual reality experience in women who were first baby, laboring without anesthesia, and who were willing to try anything. And so we had them kind of alternate using the goggles, not using the goggles. This is a kind of a randomized crossover study. But what we found is that first of all, we thought they'd get really nauseous. They didn't, so they did well. And they said it did not interfere with the birthing experience. It was great. And they had upwards of 40% reduction in pain. These are very immersive experiences. And 201, they said, you know what, you need to get this really specific for birth. That'd be really cool if it kind of was directed towards us. So that's kind of some fun things that we can see being applied to use resilience and positive activities in the perioperative setting. So just to kind of summarize, it's really important that we identify patients at risk for poor surgical outcomes and of course, increased opioid use. What we know about this tends to be patients who are more depressive and anxious, who catastrophize their pain, but often people who have high levels of preoperative pain, a traumatic surgical history, and low social support are all big predictors of who might have a problematic outcome. And then the goal is to perhaps identify some of these folks and tailor treatment. We could use prehab interventions, everything from sophisticated things like MSHOP or to these more primitive, simple paper and piggy bank types of things, relaxation techniques, virtual reality, teaching pain coping skills, and even social support, even minor things like creating even a surgery guide, somebody who literally walks through the process with patients, because patients often feel like they don't really know what's going on next, and that can be really unsettling. So those are my thoughts, and these are the wonderful people with whom I work, and not a complete list, and then some of the sponsors of our research. So thank you.
I have to push a button. Okay, I can figure this out. So we have about 10 minutes for questions, so feel free to ask questions of any of the speakers up here. There's 2 mics in the center, so please approach the microphone when you ask your question.
Thanks so much for a really, there it is. Thanks so much for a really fascinating panel. It's so exciting to hear about this problem we sort of find ourselves in as a specialty from so many different angles. I was struck by a hint of sex dimorphism in the response to the interventions that you were showing. And I was wondering if you could comment a little bit on the mechanisms that are hypothesized there. And then Dr. Hassett and Dr. Walji, if you could comment on how that potential for a gender-specific effect impacts the way that you've explored your own data about opioid use and about resilience and positivity.
Hello. Okay. Yes. Yes. In our study, unfortunately, it was just a hint. We didn't see any significant differences between males and females, and that's probably one of the caveats of this surgical model in rodents. There have been other studies in rats and mice, and they show exactly the same thing. Basically, no difference, even with greater numbers than the ones we used in our study. So in terms of differences, there are in humans. They are very clear, and I will let the rest of the panelists take over and respond to your question. But there's a clear implication of sex hormones in pain responses in females relative to males.
Generally, we haven't seen too many differences amongst, within our data, other than women really seem to love these interventions, and men pretend like they don't, but they do. Once they do them, they seem to benefit most. And even within the piggy bank, the men are almost the most excited because they pick the piggy bank for a kid or for someone else. So, yeah, we certainly consider that. We're doing a large R01 right now, looking at a very organized version of these interventions, and we will definitely look at the difference between sexes because the NIH said we had to.
Yeah, I'll echo what my fellow panelists said. We haven't seen huge effects with respect to new persistent use and some of the other things. I don't know if that's because we were using insurance claims data, which is relatively blunt. And so in some of our upcoming work, we are doing more prospective work around anxiety, depression, sleep deprivation is in there, centralized pain syndromes, and seeing if that predicts some of the opioid consumption and opioid use disorders that we see after surgery. And there may be gender differences there that we just haven't seen yet in claims because it's not sensitive enough for it.
I was just curious, on the study with sleep deprivation and then giving caffeine, have you tried to, my understanding is that you were giving caffeine before the sleep deprivation. Have you guys tried to sleep deprive, then give caffeine and see what happens?
We didn't do it, but that is part of our plan, and we are trying to figure out whether to incorporate. Obviously, after having done this study, one of the problems is the one you pointed out, and we have plans to address that, but we are now at a moment where we have to decide whether to continue testing these things in rodents or taking that into patients. So as soon as we have that figured out, we will determine what is the best timing for caffeine administration. And there are many other questions like, are chronic caffeine users as responsive as non-users? What happens with chronic sleep deprivation? It's a different animal, acute versus chronic sleep deprivation. So there may be many factors that we have to take into consideration in order to get a more translationally valid response from our preclinical studies.
Thank you all for a great panel. And actually, I was in particular interested about the targeting. You know, it seems that we're entering this ERAS where everybody gets the same thing, or we have very protocolized medicine. And I think it makes sense to personalize medicine and adapt or pick, strategies that are going to work for certain people. And I was interested in how you, for your big studies that you're going to be doing, how you set the cutoff. And, because probably anyone could benefit, but like at some point you say, okay, now this person's going to benefit enough, so we're going to give the intervention to them, because it seems like it's sort of tricky. It's like a slippery slope.
No, that's a great question. It's actually something that Jen and I are talking about putting in an R01 in October, and we've been kind of wrestling with this too. How do we allow people to kind of pick? I think there's a lot of natural inclination towards one type of intervention versus another. Sounds like it's just ridiculous. They wouldn't benefit. So I think that's more of the trend, is to kind of offer them to people, or kind of as here are 4 offerings. What seems to be the thing that you like the best? Because I think people tend to persist and do something that they feel that they've chosen and they value versus something that they're told to do that doesn't make sense to them. Any thoughts? Yeah. Thank you.
I don't know if I have the right, I'll just speak up. Giancarlo, you gave the rats caffeine so that they could get a better night's sleep. Are they different than us? I mean, does it make them sleep or allow them to sleep?
Well, no. This was just a treatment option to counteract sleep debt in these animals. Of course, the best choice is to put more emphasis on natural sleep. I mean, it's non-GMO, natural, cheap, all those things. So the idea is to make the patients sleep better. And I omitted to mention that the importance of this study, or how this study fits well into the reality of patients, is that you see patients that drive from many parts of Michigan, from far away in the morning prior to surgery. Good luck getting good sleep when you get the call, we need you by tomorrow, and you will have surgery. So that, in addition to epidemiological data showing that at least in North America, 1 every 3 adults are sleep deprived, I think makes a good case for this. But the first option is always try to make the sleep better without this intervention. In our case, we saw some hyperactive rats after caffeine injection for a few hours, and then they crashed, and supposedly they had more sleep. That's something that we have to look into and determine whether, one of the questions is whether these animals did a lot better in terms of their post-op pain because of caffeine, or because after that hyper time they went to sleep and they had deeper sleep before surgery. So that's, thank you.
Dr. Walji, sorry, golly, you can ask a question.
Sure, yeah. So you're going back and forth about rodents versus going into humans. I would definitely say go into humans. There's probably no population more sleep deprived, acutely at least, than a preoperative surgical population. So a question I had for the panel, I wanted to take this back just a little bit to the scholars' focus on people, on our audience developing academic and research careers. And when I think about perioperative pain management and opioids, I think as this panel has demonstrated very well, it's not just an anesthesiologist's problem. It's clearly there's benefit to a wide range of disciplines approaching this problem. And so that makes me realize that, sure, the thing that we need to do with really approaching any problem, it doesn't have to be perioperative pain, is to facilitate multidisciplinary collaboration. And so I was wondering if each of you could speak just briefly about how you've been actually able to do that. How have you been able to do that? What forums and what opportunities have you had where you've actually been able to bridge that gap from, it could be within the medical school, or it could be to another discipline outside the medical school altogether. What have been some of the critical interactions that you've had that have brought on a completely different viewpoint of the problem that you're approaching, and the benefit that you got out of that?
Sure, I can start. I think Afton made a great point that kind of talking about your interests and having your elevator pitch well honed, so that when you interact with all these different people, if it's in the operating room or the hallways or a lecture series, you're ready to go with kind of, here's my 30-second spiel. And that really allows you to find connections quickly, which has been a great opportunity for us. I will say, so within, at Michigan, I'm under a different section than Mike, who's in transplant surgery. I'm under plastic surgery, and then there's the Department of Anesthesia. And so sometimes at large universities, administratively and academically, team science gets hard when it comes to, well, how is this person going to navigate through the system, and who's going to sit at this cubicle, and all those kinds of things. So I think that the trust and open communication has been fantastic, and just kind of remembering that the value is in the partnership, and the people that you get to work with are the ones that are going to help us do the important work. So being mindful about staying on the good work that we get to do is probably key, so that way all those little administrative bumps in the road don't create roadblocks that prevent you from working together.
That's great. I just want to add one thing too. Go to stuff. Go to lectures, go to SIGs, go to conferences. You're already ahead of the game because you're here, so that's a great step. But that's how you start to meet people, and it seems like once you meet a couple people, these networks almost build themselves. But it's usually just taking those first steps. So kind of the combination of having that elevator pitch, knowing what you are interested in, and how to communicate that, and then just kind of showing up and talking to folks.
Well, I don't have anything meaningful to add, really. I think you covered everything. One last thing I would say is find good mentors, choose wisely, and that is huge for your careers.
As we had heard earlier today, in numerous talks about mentorship. So if there's no further questions, I'd like to thank our panelists again for such great presentations and give them a round of applause.